Good afternoon, everyone. My name is Sahar Mohammed Hesham, and I am infectious disease clinical pharmacist with a special focus on the antimicrobial stewardship and infection management. Today, I will be presenting to you one of the most important and interesting real case for the surgical site infection, guiding you through the patient initial presentation, the management approach, and how the culture results will influence our final decision on antimicrobial. Will be on the case part 2 on Friday, inshallah. This case will highlight the vital role for the infectious disease specialist, whether a pharmacist or physician, in verifying the appropriateness for the antibiotic choices and whether they should use single or combination therapy and whether it is justified or not. Such decisions are very crucial and critical for applying day-to-day stewardship concepts, ensuring that the treatment for both guidelines based and according to the patient clinical situation and ensuring low resistance and ensuring patient safety. Let's start by discussing our patient case. This is a male patient post-CABG. He did his surgery 40 days ago. As you know, the CABG surgery is one of the most important cardiothoracic surgeries. It's open heart surgeries and it is one of the clean procedures. The patient came to us complaining from surgical wound infection, okay, and he was, as I mentioned, he was previously done his surgery 40 days ago. Okay, so the doctor has been diagnosed him as having a surgical wound infection or as having surgical site infection, and he classified this surgical wound infection as a deep skin and soft tissue infection. Okay, deep. Why he classify his wound infection as a deep surgical site infection? Because the timing for the appearance of the wound infection is exceeding 30 days. It's after 40 days. So if it is within from day 0 to day 90, usually it is being classified as a deep. Why it is important to classify the surgical site infection? Because according to this classification, we will consider which antibiotics we will use it, and also we will consider if the patient will need to start antibiotics or he can be managed safely without antibiotics. This is very important. So the doctor decided to start meropenem and levofloxacin as an empirical therapy. Okay, so the doctor decided to start dual antidomonal agents, very broad spectrum antibiotics. Meropenem is covering the staph, but also it covers the Pseudomonas, and levofloxacin, it also covers Pseudomonas. Okay, so we considered to use both agents that has a very broad spectrum agent. So he considered to start empirical therapy and by double antidomonal. Also, he decided to take culture from the pus, okay, to send it to the lab to know which organism is responsible for the infection. Now the patient is on VAC, okay, and he is vitally stable except he develops fever. Fever is one of the systemic symptoms that indicates that the patients will require antibiotics, okay, empiric therapy, as we will see in the guidelines. This is a snapshot from one of my live discussion in my infectious disease courses and consultation. For more details, or if you would like to join the next sessions, you can contact me directly on the WhatsApp, and this is my number. After a long discussion with my attendees in order to know how they think about the case and what's the response to regarding the case, their opinion is to start antibiotics empirically. Second, they emphasize choosing broad spectrum antibiotic that cover gram positive and gram negative bacteria, and also to include antibiotic that has MRSA coverage. Finally, they agreed that the patient should not. They disagreed with the physician that the patient should not start on VAC. So their opinion is not their opinion that VAC is not recommended for this case. Let's see the opinion of the guidelines, and whether they are agree with the opinion for my attendees and also the opinion for the physician. For those who are not able to get the information from the guidelines, I do recommend that before you are searching about the guidelines, you must know which infection you are treating. So we are treating surgical site infections, so we need to go back to the guidelines for the IDSA 2014 for the practice guidelines for the diagnosis and management for skin and soft tissue infection. Okay? As we go for the guidelines, they are classifying the the skin and soft tissue infection as a general with non-purulent and purulent. Non-purulent is the necrotizing infection, cellulitis, and erysipelas, and the purulent is the carbuncle, furuncle, and abscess. But our case is not skin and soft tissue infection that is related or under the purulent and non-purulent. It has a different classification, which is one, the infection algorithm. Because as we know that surgical site infection is one of the simple skin and soft tissue infection. So according to the IDC guidelines, they are being classified this infection as a simple, and they do a separate algorithm for its management. So when the patient do the operation, is the fever appear within 48 hours up to 4 days, or if the fever appears after 4 days? In our case, the fever appears after 4 days, almost after 40 days. Okay, so we will be at that side. Is the patient had erythema or induration, or the wound is normal? If the wound is normal, so you are seeking for sources other than fever. But if the patient is experienced any erythema or induration at the wound, so you will ask yourself one more question: is the patient has systemic symptoms? Yes or no? If the patient has a temperature is more than 38, or white BCs more than 12,000, or erythema more than 5 centimeter from the incision with the induration with any necrosis? If yes, so start antibiotic. If no, so only dressing is appropriate and no antibiotics should be started as an empirical therapy. So our case is being experienced fever. So we are at that site. So beginning antibiotics is the recommended option. So we will start antibiotics. Again, we need to know whether or not the choice of the antibiotic is appropriate. So we will go through if the patient has a clean wound trunk in the trunk, head, or neck, or extremities, or the patient has a wound in the perianum, operation on the GIT, or female genital organ. In our case, the patient is being classified as has a clean surgery because open wounds or open heart surgeries in the sternum. So it's be considered as a clean wound. So the patient should start cefazolin or vancomycin until MRCE is ruled out, or even if the patient has severe beta-lactam allergy. So we will not need to start a broad spectrum antibiotic to cover gram-negative. We only just start with cefazolin or vancomycin. Okay, if the patient has MRSA risk factor. It's very important to know that other wounds related to the perianum operation or GI or female genital tract, the patient should start cephalosporin plus metronidazole, but the choice of the cephalosporin usually the third generation cephalosporin, levofloxacin plus metronidazole or carbapenems. And as you see that the guidelines does not recommend all the fluoroquinolones, they only recommend the levofloxacin. And this is very important. Why this is very important? Because levofloxacin is usually covering the strep, okay? And the ciprofloxacin usually has a weak coverage for the gram-positive, especially strep. So it's recommended from the fluoroquinolones to use levofloxacin only. It is not recommended at all to use all the fluoroquinolones. Okay, this is the part, this is the footnote that explain when to use the vancomycin. Okay. Also, we need to know the patient risk factor for MRSA, if we are being breed with each other, the preferred treatment for surgical site infection. As you see, this is the recommendations. Okay, it's the same as the algorithm, but here being talking about which risk factors that if the patient has, then the patient need to start MRSA coverage or the agent that cover MRSA. First, the recommendation is first generation cephalosporin or an anti-staphylococcus penicillin covering MSSA. Vancomycin, linezolid, or daptomycin, telvancin, or ceftaroline, where the risk factor of MRSA is high, like the patient has nasal colonization, prior MRSA infection, or recent hospitalization, or recent antibiotics. Okay, so our patient does not have these risk factors, so no need to start anti-MRSA as an empirical therapy. But if the patient is being experienced any of these risk factors, so it's recommended to start anti-MRSA agent. Okay, especially that the patient does not have any allergy from cefazolin, so he can start cefazolin safely. Let's start to read the recommendation from the up-to-date. Okay, why I choose to not only to follow the guidelines for the IDSA, because it's has been published in 2014, which is almost 10 years ago. This is very old, so we need to read from other source in order to know whether the recommendation has been changed or not. So let's start to read with them, to read in the recommendations for up to date. Okay, and compare the both recommendation to know if there is a difference or not. Let's start. Okay, this is the management for surgical site infection. Let's start for the indication for antimicrobial agent. Okay. Let's read with each other the indication for the antimicrobial. The need of antimicrobial is being determined by the extent of infection, presence for systemic manifestation, patient comorbidities like chronic glucocorticoids or diabetes. Usually, the antibiotics are required in the setting for surrounding cellulitis or the presence for systemic sign and symptoms, as we mentioned, as the patient has one of the systemic sign and symptom like fever. While antibiotics are not always necessary to treat superficial infection, usually the antibiotics are nearly always required for deep and organ space surgical site infection. Okay, so the up-to-date recommendation is being agree with us that we will start with antimicrobials. So empirical antimicrobial selection depending on the surgical site and the minor to the prophylactic antibiotic to prevent surgical site infection. The selection is usually based on the initial gram stain. Okay, if you are taking culture, wound class, whether it's a clean wound or a wound it's not clean contaminated or clean contaminated, prior antibiotic exposure, because it will this is prior antibiotic exposure will guide us whether or not we'll start anti-MRSA, as I mentioned in the guidelines, okay, or whether the patient has been exposed to certain class of antibiotics, so it is not recommended to reinitiate it when there is infection. History for colonization of antibiotic-resistant organisms like methicillin-resistant Staph aureus or local antimicrobial resistance pattern, which is very important. If your patient develop an infection and been readmitted and he do his operation at the same hospital and you have a local antimicrobial resistance pattern or you have an antibiogram, you should follow this antibiogram to know which organisms are being prevalent in this hospital. The most common pathogens isolated from infected surgical wound is Staph aureus, coagulase negative, strep, and also Enterococcus species. Empiric gram negative is often not necessary. We usually do not focus on the gram negative, okay, especially except if the patient has wound grossly contaminated traumatic abdominal injury or in the gastrointestinal tract or perianum, or if there is an organism other than the skin flora are being involved in the infection. So the empiric gram negative is often necessary. As you see there is the doctor decide to start not only 1 gram negative, he decide to start two agents for the gram negative, both for the has an anti-pseudomonal, and both are broad spectrum. And then he then up to date recommend that definitive antimicrobial treatment is usually guided by the clinical response if available and wound culture and sensitivity. Okay, there is very important also to address the use for VAC or negative pressure wound therapy. As you see that negative pressure wound therapy can be used earlier in the treatment of surgical site infection is controversial. It's not recommended to start VAC on early on the surgical site infection, because too early placement for the VAC may lead to failure for the adequate debridement of the wound, because as you know that the VAC is being replaced or changed every once every 3 to 5 days. Okay, so there will maybe a failure in wound monitoring, and wound may not be adequately monitored, and maybe there is a progress in the surgical site infection. Okay, so it's not recommended to early start on VAC. Maybe you can start on VAC when the wound become clean. Okay, sometimes if the patient is diabetic or have any reason that will compromise the wound closure, there may be the wound, maybe the wound become clean, but still the wound open. So at this situation, you can use the VAC, but it is not recommended to start using VAC when the patient is being experienced surgical site infection and there is a pus. Okay, this is our recommendation. Regarding the patient case, we decide whether or not the patient will start antibiotics, which choice of antibiotics most appropriate, and also whether or not it's recommended to use VAC. Finally, don't miss the next part from the case. When the culture appears, we will read with each other the case, the culture, and depending on the culture itself, we will start antibiotics. According, and also the culture has an MIC, so it will be very interesting to read the MIC and to start to use the MIC in guiding the antibiotic choices. So don't miss the part 2 in the next Friday. Uh, Thank you for your attention, and goodbye.